to improve response to hormone therapy for hormone receptor positive, breast cancer. So if we look at, let's see if I can make this work. There we go. So if we look at hormone receptor positive disease, and we're going to specifically focus on HER2 negative disease, we know that it's the most common subtype of breast cancer, more than 50% of breast cancers. And recently there was a publication in the New England Journal of Medicine from something called the Early Breast Cancer Trialist Group, which is a group based in the UK, but where they take trials from all over the world and put them together in something called meta-analyses. And they had over 46,000 women in this trial that had received 5 years of endocrine therapy, mostly tamoxifen, for early stage breast cancer. And then they looked to see if you were well 5 years after your diagnosis, what was your risk of having a metastatic recurrence from year 5 to 20? And it was surprising because it looked as though if you took 5 years of tamoxifen, and again, remember this is older data, and so they didn't measure HER2, people didn't get Herceptin if they had HER2 positive disease. The hormone therapy was tamoxifen and not aromatase inhibitors. There was a lot that was not known in those early days in patients who are out, who now have data from 30 years ago. But what was intriguing, I think, was that there were continued recurrences, regardless of the kind of cancer you had from year 5 to 20, and that the risk of recurrence was still, in that late time frame, dependent on how much cancer you had at diagnosis. Now there are a lot of groups that are working on various tests that look at genes, really RNA, we call gene expression, to see whether or not we can predict which cancers have a higher risk within these categories of bigger or smaller or node positive or node negative cancers, and then also predict who's going to benefit from continuing their therapy out to 10 or 15 years, and in the future, who will benefit from taking targeted therapy for early stage breast cancer. Now, we're focusing on metastatic breast cancer, recurrent incurable disease on this call, and what we know and what's been frustrating for us forever is that patients do have often a very nice response to hormone therapy, but it's not long enough, and we see sequentially shorter periods of control. So if you go to the first-line hormone treatment, the cancer is controlled for a certain time period, and then the next treatment, maybe it's shorter. But our challenge in trying to look at things which will prolong that time that the cancer is controlled has been balancing the better responses with quality of life. So you want to control the disease, obviously, but you also don't want to create a situation where people are so sick they aren't really enjoying their quality of life. So that's a big issue, and that's something that we've really thought a lot about as we've been studying these new drugs. So there are a number of different ways that have been identified by our laboratory colleagues to help us think about mechanisms that lead to resistance to hormone therapy. So if you're being treated with a hormone agent, you could have a good response in your cancer and then have the cancer eventually develop resistance to that treatment. You could also have a cancer that never really responds very well to the treatment that you've given it, so-called upfront or de novo resistance. So our laboratory colleagues have tried to model these cancers in animal models with cell lines to try and understand what leads to that resistance. So there are a couple of areas which are called signal transduction pathways. These are things that get turned on and lead to more rapid and more resistant cancer growth. They're pathways or markers. And people on this call, of course, understand looking for markers or genetic factors that are turned on within the cancer that could potentially be targeted by targeted agents. And that's the same idea. There are also other areas that are being targeted that I've put in gray there below because those are still very much in progress. One area is using something called histone deacetylase inhibitors, and there is a randomized trial going on with a drug called entinostat, and it'll be interesting to see what those results show in the next couple of years. We don't have those results yet, so we won't talk about that in detail. There's also a lot of interest in areas that result in resistance to one kind of hormone drug versus another. And one recent area that's come to light is called the ESR1 mutations, estrogen receptor mutations. And it turns out that in order to get to those mutations, you actually have to have seen hormone therapy. So for most people, they're not going to have a mutation unless they've already been treated with a hormone drug, and eventually their cancer has developed resistance. One of the mechanisms of resistance can be a mutation in the estrogen receptor, so that they no longer, the cancer can respond to blocking production of estrogen. This is an area which is just coming to light now, and it's not really ready for any kind of clinical use, so we won't talk about it further. Now, as we go on and we talk about the first area, the first pathway here, so the PI3 kinase mTOR pathway, this is, I think, important, although it's not our primary topic today. I just thought that I would mention it. So here you have this relatively complex picture, a cartoon of the cancer cell. Here is the nucleus, or the powerhouse of the cell, and the DNA. So here's the estrogen response element. So the estrogen receptor actually binds to the DNA and tells the DNA to turn on other pathways. It's really very complicated. So the idea behind this whole thing here is to understand what pathways could turn on the estrogen receptor, even if you blocked it. So let's say you took a hormone drug that blocked production of estrogen, like an aromatase inhibitor, letrozole, anastrozole, exemestane, or you took a drug like fulvestrant, which blocks the estrogen receptor. Are there other ways that the tumor could get turned on to grow that would result in activation of this pathway? So the most common pathway that's altered in breast cancer is called PI3 kinase, phosphatidylinositol 3 kinase. It's an enzyme. Anything that ends with kinase is an enzyme. And this enzyme gets activated when any number of a different group of receptors on the outside of the cancer cell get activated. The little P's are being phosphorylated, having a phosphate stuck on it, which activates them. When PI3 kinase gets activated, it starts what we call a cascade. And the cascade goes down to activate other areas, something called AKT. There's actually a new agent that's being tested that's an AKT inhibitor in triple-negative breast cancer. mTOR, mammalian target of rapamycin. And then at the end, you actually turn on the estrogen receptor. So if you could block these, it would make a lot of sense. So we wanted to block PI3 kinase, but until recently we didn't have good drugs. So the first drugs that were available were those that blocked mTOR, and the drug called everolimus is approved in combination with hormone therapy, actually, in the treatment of metastatic breast cancer that's already grown on other hormone drugs. Now, not to leave out this pathway over here, but this one doesn't seem to be one right now that we can target well for a hormone receptor positive disease, but it is one that's being targeted actively for triple-negative breast cancer. There are now MEK inhibitors, so-called, that are being studied with immunotherapy. But we do know that this pathway gets activated, and it's overactivated, and it really drives resistance to hormone therapy. So what could we do? Well, we did a whole lot of preliminary studies with the drug everolimus, or Afinitor, which is a drug that blocks activation of mTOR. And we ended up studying it in combination with a hormone drug called exemestane. And we did this in women whose cancers had already grown on either letrozole or anastrozole. And what we found was that the disease was controlled, that's this progression-free survival, twice as long if they took everolimus than if they didn't take everolimus. So there was a doubling of this time to progression or progression-free survival. Now, what does all that mean? This is centrally evaluated. This is by the local doctors. But what you can see is this time is not as long as we would all like it to be, but 11 months is a lot better than 4 months. So that's pretty good. But remember, as we're thinking about this, we're also thinking about quality of life and whether or not an agent which helps somebody have disease control for twice as long results in a lot of side effects that makes them miserable. And if it doesn't help everybody live a lot longer, maybe it's not worth it. Well, survival was an endpoint on this trial called Bolero 2 that led to approval of everolimus. But You know, it's interesting. In order to have a trial that can show a survival difference in hormone receptor-positive breast cancer, you need so many patients that the trial is not doable. And that's because cancers develop resistance in different ways, in different rates, and depending on where the patient is, unfortunately, they may have different access to treatment. So, for example, we know that if patients are treated in some countries, once they finish trial therapy, they may have very few options unless they're able to pay out of pocket or travel. So that may affect somebody's survival very much if they're from one place versus another place. Also, some of the cancers grow in different ways or develop resistance more or less quickly, and that also affects survival. So it was really important for us to understand whether or not we control what the side effects were and whether or not we could control them, and I'll show you that in just a moment. There have been other studies which have shown that you can combine everolimus with other hormone drugs like tamoxifen or fulvestrant, also known as Faslodex, and it also shows very similar differences in how long you can control the cancer. So the biggest side effect that we saw in Belle and with everolimus and other drugs of this class has been mouth sores. Well, that's pretty miserable. You know, you're taking a hormone drug, you want to feel better, you don't want to have mouth sores that prevent you from eating. So we recognize that these mouth sores look very much like the kind of mouth sores that people get who have autoimmune diseases. So we actually started a steroid mouthwash trial, and we gave these women a steroid mouthwash to swish and hold in their mouth 4 times a day for the first couple of months, because all of the mouth sores, and it's just to help you understand this curve, this orange here are people who got mouth sores who were on everolimus. You can see here, everolimus plus exemestane. These are the placebo patients who were taking hormone therapy only. What you can see is this is 2 months. Almost everybody who was going to get a mouth sore got it in the first 8 weeks. So we only gave people the mouthwash for the first 8 weeks. So what you can see here is that if you just took everolimus, you had significant mouth sores. If you look at the green and the red together, more than 30% of patients had significant mouth sores at least once. With the steroid mouthwash, we saw something completely different. We went from about 39% of patients with no mouth sores to almost 80% of patients with no mouth sores. We eliminated the most serious kind of mouth sore called grade 3 and markedly reduced the grade 2 from 20 to 2.4%. So based on this data, which was published this year, the label for everolimus now recommends that patients use this steroid mouthwash. So when we're balancing out benefits and risks, we always want to take this kind of thing into account and understand how we can educate everybody about management of these side effects. We don't have to take them at face value. The other thing I think that's important to think about is PI3 kinase inhibitors. So there's a new class of drugs that inhibit PI3 kinase, this enzyme at the top of that pathway I showed you. The agents that were tested so far were too toxic or they didn't work very well, and one of them is this drug buparlicib. But what we did show is that you could get samples from the blood and find some circulating tumor DNA. It's just free DNA circulating around in the blood when you have cancer. And you could look to see if your cancer had a mutation in that PI3 kinase. They compared the blood results to the primary tumor. And what you can see here is that the numbers are almost identical. In other words, it suggests that blood might be just as good a way to look for mutations that you could target with new agents as doing a biopsy. Biopsies are painful, they put people at risk, and often we don't get enough tumor to look at what we're wanting to look at. So this, I think, is a really important and exciting advance. They also showed that despite the fact that this is a crummy drug, that it actually benefited patients whose tumors were mutated in PI3 kinase. Those who didn't have a mutation, called wild type, didn't seem to have any benefit. And what you're looking for really is the difference between the white and the green curve. So there are a number of studies going on with new, much better tolerated, specific PI3 kinase inhibitors, a drug called Selective and Alpelisib. These trials, which are randomized to placebo or not with the hormone drug fulvestrant, so placebo or the PI3 kinase inhibitor, have completed enrolling patients. and we expect to see results next year. Having had patients who were with disease response for 4 years late in their treatment course with alpelisib and fulvestrant, I'm really excited to see these results, and I'm hopeful that one of these drugs will get approved for clinical use within the next year or year and a half. They still have side effects, but the side effects are much less than what we saw with those other first-generation drugs. There are also some new drugs that are being studied that block both PI3 kinase and mTOR. One drug called gedatolisib is given intravenously weekly, and we've seen some amazing responses. Trying to manage the side effects and understanding how to give these drugs is our next challenge. Now let's talk about cyclin-dependent kinases, which was the main topic here. This is an interesting area because the cell is always cycling, right? So it's growing. We call that proliferation. What happens is it has to go through this phase where it's almost like a spring, you know? So you wind up the spring and then you let it go and then it pops, right? So that's what the cell cycle does. You actually have to first synthesize the material you need to grow and divide. So you go through this whole cell cycle process of sitting back and gathering together your resources and making new proteins and everything that you need in DNA, duplicating your DNA, and then eventually you go into the cell cycle and you make more cells, right? So that's what they're talking about here. And what we know is there are many enzymes that are really important for the cell cycle. And cyclin-dependent kinases, remember kinases are enzymes, so these are enzymes, 4 and 6, because there are a whole bunch of them with different numbers starting at 1. Cyclin-dependent kinase 4, 6 are really important, and they're dependent on this called cyclin D. They bind together, and when they bind together, they block the ability of your body to stop the cell from cycling. So it's an interesting and complicated concept. What happens is that if a cyclin-dependent kinase is active, then your body can't stop the cell from growing. But if you block CDK4/6, in many cases, the body is actually able, through a protein called retinoblastoma, from stopping the cell from growing. It gets back its smartness, and it says, I don't need more of you. Stop growing. So that's what's really important, and it's this whole transition phase where you actually start the division. Turns out that this is really important with hormone therapy. So the growth of hormone receptor-positive breast cancer is dependent on this protein, cyclin D. The estrogen receptor targets it and turns it on and helps the cell to grow. Cyclin D then activates the cyclin-dependent kinases 4/6, and the cell is going. So if you could block this, CDK4/6, then it doesn't matter what the estrogen receptor is doing for cyclin D. If you could, along with CDK4/6, get rid of estrogen or block the estrogen receptor, it would work even better. So that's the whole concept behind this. CDK4/6 inhibitors existed for a long time, and they actually have been put sort of back in the shelf. And the reason why they were on the back of the shelf is because people thought that they had toxicities, and the early ones did. But these more specific ones were actually okay. They seemed to do okay, but they didn't really know how to use them. So our colleagues at UCLA, Rich Fenn and Dennis Lehman, took their little library of cell lines out, and they found that this CDK4/6 inhibitor, Palbociclib, now known as Ibrance, blocked hormone receptor-positive breast cancers. Those are these blue ones. And what those low lines mean is that if you dropped the CDK4/6 inhibitor in here, the cell could not grow. It also works against HER2-positive cancers. Those are the green ones. It didn't work at all against hormone receptor-negative, HER2-negative, so-called triple-negative breast cancers. So this was kind of exciting, and it led to initial clinical trials that were really exciting, and then eventually randomized trials, and now approval of 3 different CDK4/6 inhibitors. They're called selective because they don't block all the other CDKs, of which there are many, many. So there are 3 drugs. Palbociclib was the first one, Ribociclib the second, and then most recently Abemaciclib. Those drugs have a variety of different brand names. I think, let's see if I can get them. I don't think I remember the Abemaciclib one, but Palbociclib is Ibrance, Ribociclib is Kisqali, and Abemaciclib is the most recently one approved, so I can't remember its brand name. It starts with a V. we tend to refer to them as their generics. In any case, you can see that the structures look different, but Palbociclib and Ribociclib are very similar. Abemaciclib is a little more different. These two drugs are given for 3 weeks in a row, and because blocking the cell cycle actually causes a low white blood cell count and low neutrophils that fight infection, a kind of white blood cell, you have to give a week for the bone marrow to recover. So you give a week off every month. Abemaciclib doesn't cause as much suppression of the white blood cell count and neutrophils. It causes more diarrhea, which is intriguing, and we're not exactly sure why, except for that we know it blocks, for example, some of the CDKs more than these drugs do. It's a more potent blocker of some CDKs, and the specific ones aren't important because we don't actually really know why it has different side effects. But because of that, Abemaciclib is given continuously rather than 3 weeks on, 1 week off. The first drug to be approved was Palbociclib, as I mentioned, and we'll talk about all of these drugs. So the way new drugs are tested is first in a trial where you just look at toxicity, and they seem to be really well tolerated. And then they did a trial with hormone therapy and randomized patients, but it was what's called open label, where you didn't know, you knew if you were taking the CDK4/6 inhibitor or not. And everybody got hormone therapy. So there's no, total placebo arm when you're treating a disease where you know a treatment will work. So you have to give the standard of care in one arm, and then in the other arm you give the standard of care plus. So in the initial trial, which is called the phase 2 trial, they showed a doubling of the time that the cancer was controlled, and it seemed to be really well tolerated. Even though the neutrophils were really low, people didn't get infections. They didn't get sick from it, and if you just waited a little while, they got better. The neutrophils came back. So it was kind of exciting, those first data. So then that rapidly led to these trials called phase 3 trials, which are definitive trials that can lead to drug approval. And what you can see in this slide is that there are a lot of patients here, almost 700 patients in both trials, right? So this trial randomized 2 to 1, so twice as many patients got Palbociclib with letrozole than placebo and letrozole. This one randomized the same number to both arms. So for different study designs and not important. But what's really important is they said, okay, let's see what we can do in patients who haven't had any hormone therapy for metastatic breast cancer. And they didn't relapse while they were on a hormone drug like letrozole. So let's say you had early stage breast cancer and you were on tamoxifen and you developed a recurrence, you would be eligible for this trial. If you were on letrozole or anastrozole or exemestane, you would not have been eligible for this trial. Remember that these two lines tell you how long the disease was controlled, and what you can see is in this definitive trial, it's an almost doubling. So 10 more months of disease control with the addition of Palbociclib versus placebo. Very similar data with Ribociclib, 9 more months of disease control with Ribociclib. So that was really exciting for us. I mean, if you could have your cancer controlled when you started your first treatment for 2 years as opposed to close to 1 year, that would be good. If the treatment's well tolerated and you feel about the same as taking a hormone drug, that's worth it. So the biggest issue for us has been, if this works so well, is there anybody who doesn't need the drug? So the next study we saw was with Abemaciclib. This data was just presented and published this year in September, and the drug was then approved for treatment of metastatic breast cancer. So they reported their data very early, so they haven't yet reached their median for how long people's disease is controlled with Abemaciclib, but you can see that it's very similar to what we saw with the other drugs. It'll be almost a doubling of progression-free survival, or the duration of disease control. These are blinded studies, double-blind. Nobody knows which drug they're on, but because you cause totally we can recognize these side effects with a 10-foot pole. Generally, you know which drug a patient was on. One of the things we've always wanted to see is whether or not there's a group that benefits more or less, and this is too little. But I just wanted to show you this to give you an example of what we look at. This solid line means that the two drugs are equal, right? So within a subgroup, there's no, the one giving the experimental drug isn't better than not. This other dotted line here, and it's the same with all of them, that indicates that the experimental drug is better than the placebo. Remember, everybody got hormone therapy. what you can see is all these little dots for everything that we can look at, where your cancer was, how long you had cancer, whether you got prior hormone therapy. Patients did better if they got the CDK4/6 inhibitor versus not, all of them. And so we haven't yet identified any subgroup or any biomarker that predicts relative benefit from getting the drug versus not. So it's hard to figure out who shouldn't get a CDK4/6 inhibitor. Well, of course, side effects are really critical, and I mentioned this low neutrophil count called neutropenia is important, but people don't get an increase in fever. They do have fatigue, so that's one side effect, but it's not usually horrible fatigue. And then loss of hair can happen in about a third of the patients. Mostly it's very mild, but a small number of patients will have really significant hair loss, and we don't know why that happens. Abemaciclib is a little bit different, and what they found in Abemaciclib was that a lot of people had diarrhea, so 80% of the 100% of patients had diarrhea. Only about 10% of patients had a lot of diarrhea, so this is like, more than 8 episodes a day. And basically, understanding the drug improves that. They reduced the dose of the Abemaciclib, and now the diarrhea rate is much lower. So, it's always a question about if you were somebody who had chronic diarrhea, maybe you would choose one of the other CDK4/6 inhibitors. They also found some differences, and what I'm showing you on the next slide here is comparing these different studies. That, you could see that the duration of disease control is actually very similar between these drugs. It's amazing how similar it is. And these are all oral treatments, so that gives people a lot of freedom. The one thing MONARCH 3 showed with Abemaciclib is that people who had a long time until they developed relapsed cancer, they might do kind of well regardless of whether they get a CDK4/6 inhibitor. What TFI means is treatment-free interval. And if you had a time from when you finished your hormone therapy for early-stage breast cancer until you developed metastatic breast cancer of more than 3 years, those patients did really, really well. Like their time for disease control was long enough so that they didn't actually reach a median in either arm yet. It might still be that the CDK4/6 inhibitor is 4 years versus 2 years, without. We don't know. It's too early to know. But clearly, for the patients who had a short time, the CDK4/6 inhibitors made a big difference. And I'll just briefly mention this trial, the Falcon trial, which was looking at just hormone therapy, so anastrozole versus fulvestrant, in patients who had metastatic breast cancer who had never received hormone therapy. So these patients couldn't receive hormone therapy for either early or late-stage breast cancer, so it's kind of a funny population of patients. And what they found was a little bit of an improvement in disease control, but nothing like what we saw in these studies, right, 2 years. Then they looked at this subset of patients, about 200, who only had bone or lymph node, cancer in their bone or lymph node. And what they found there was that some of the people's disease was controlled for a very long time with fulvestrant versus a shorter time with anastrozole. And this is interesting because there's now a study going on in Europe looking at taking these patients and giving these patients a CDK4/6 inhibitor. Maybe their disease would be controlled for a median of 4 years. That would be amazing, and the first time we ever saw that. So, of course, CDK4/6 inhibitors have also been tested in patients whose cancers recur on an aromatase inhibitor. So let's say you're taking letrozole or anastrozole and you develop metastatic disease, or patients who already got those drugs as treatment for metastatic breast cancer. And what these patients were randomized to was getting this drug fulvestrant given by injection once a month with either a placebo or the CDK4/6 inhibitor. Only Palbociclib and Abemaciclib have data so far in this setting. Ribociclib data is expected next year. So if you look at the different trial populations, MONARCH 2 had a group of patients who never got chemotherapy for metastatic breast cancer, but PALOMA 3 had about a third of the patients who had chemotherapy before, and that seemed to shorten the time of control. So, sometimes doctors and patients, of course, will feel like if they got chemotherapy, it's more aggressive and it would be better treatment for their metastatic breast cancer. But actually, chemotherapy has more toxicity and it generates resistance just like hormone therapy. So it may actually just give you side effects without providing a lot of benefit. And I'll show you that here. So here's the data from these two trials looking at Abemaciclib or Palbociclib with fulvestrant. What you can see is that with fulvestrant alone, after an aromatase inhibitor, it's a little under 5 months that the disease is controlled in the median. When you think about medians, it's really important to keep in mind, some people are shorter, some people are a lot longer. And then with the Palbociclib, it was almost a year. And Abemaciclib, these people hadn't gotten chemotherapy before. Their control rate on fulvestrant was 9 months versus 16. So the differential here is the same, but these people had the benefit of not getting the side effects of chemotherapy, and they could stay on less toxic therapy for longer. So to me, it's sort of an argument for not using chemotherapy too early in the treatment of metastatic breast cancer, because you might feel a whole lot better and have disease control without that. And then I just also wanted to show you that the differences actually in terms of benefit with everolimus are very similar to CDK4/6 inhibitors, and it seems like there's no resistance that crosses over. So for example, if you had hormone therapy and a CDK4/6 inhibitor, you could go on to get hormone therapy and everolimus as a next step. And that would be good, right? That could provide a lot of benefit for you, particularly if you can control the side effects of everolimus. Now, there are different subgroup analyses that have been done looking to see whether or not you can treat patients who are older with these drugs. Turns out that older patients have a little bit more blood count suppression or decrease in their neutrophils, but they do fine. There's no more side effects over time. What you see is what you get. You don't get cumulative side effects. And then patients who never had any hormone therapy before seem to do really well with these. At 12 months, most of the patients were still disease control. Abemaciclib is kind of an interesting drug because the approval for Abemaciclib includes not only the combination with hormone therapy, but also as a single agent. We did a study where we gave Abemaciclib as a single agent to patients who'd had prior chemotherapy, and these patients had a lot of cancer, so liver and lung disease at 90%, and a lot of different sites of involvement. 20% of patients had a response, in other words, a big shrinkage in their cancer, but almost 50% had stable disease for at least 6 months. So this was actually kind of an interesting thing, and it led to approval of Abemaciclib as a single agent as well, although we haven't tested it after you've already had another CDK4/6 inhibitor and then had disease progression. Biggest issue is diarrhea, and my patients I educate about the risk of diarrhea, make sure they have Imodium, and then we dose reduce if patients do get diarrhea, because it's quite common for patients to get at least some. I want to mention something about overall survival. One of the questions that comes up with these trials is, are you going to see a survival benefit? Will I live longer because I took this drug? It's really hard for us to find out whether or not these drugs will improve survival because patients who are on the placebo can be unblinded after their cancer grows, and then they can go on to the drug because they're all approved. And who wouldn't? Our goal as oncologists is to support our patients. So we cross over patients all the time. So we're not going to see survival differences here, but that doesn't mean that for an individual patient, it doesn't help patients live longer. Having options is really important, and it will improve survival for metastatic breast cancer. There's also some other very interesting data with Abemaciclib in the neoadjuvant setting. These are patients with early-stage breast cancer who received either anastrozole, Arimidex, Abemaciclib and anastrozole, or Abemaciclib. And they looked after 2 weeks to see how much of the cycling of the cell had been suppressed. That's measured by Ki-67. How many of the cells are dividing? And what's fascinating is the results were really amazing with Abemaciclib. And then they had pretty good responses. After 2 weeks, all the patients received Abemaciclib and anastrozole. What they also have seen, which is intriguing, is that these tumors seem to have more of an immune infiltrate, so that brings up the question of whether or not they'll just do better overall, since immune infiltrates seem to be really good for response to treatment and outcome. So this is kind of an exciting area that's being studied more, and hormone therapy before surgery in patients with hormone receptor-positive breast cancer can be incredibly helpful in terms of understanding what the potential benefit is from hormone therapy and whether or not you could avoid chemotherapy. Also, we know that Abemaciclib and the other CDK4/6 inhibitors, it's just Abemaciclib is a little ahead in this, crosses the blood-brain barrier and that we see some shrinkage in brain tumors that are treated with Abemaciclib. This is preliminary data from a very small study of 23 patients, and you can see only 2 patients had a partial response. But some patients had stable disease for at least 4 months, and then 2 patients for 6 months without radiation, just with Abemaciclib. So maybe if we gave this earlier, we could potentially even prevent brain metastases. And of course, I have a picture of one of the 2 patients that had a very good response, a patient who previously received radiation to the brain, as well as focal radiation called stereotactic radiation, or CyberKnife. And you can see the brain tumor here, and then after 12 cycles, so 12 months of Abemaciclib. So very intriguing. We don't know how many patients will respond, but it is quite intriguing and exciting. So of course there's resistance, and we want to prevent resistance. So what can we do? Well, there are some combination studies that are going on combining the CDK4/6 inhibitors with everolimus and hormone therapy, but these are toxic, and in fact this triple drug combination was too toxic to move forward. This one we're actively studying with this gedatolisib that's given IV weekly, obviously not ideal for patients. So I think we're going to see a lot of this in the future, and maybe that will help us decide what to do with patients and offer the best quality of life, survival, and disease control over time to understand how these agents work the best. I think most patients will receive CDK4/6 inhibitors first because that gives us the longest disease control in most patients. And then the question is what to do after that, whether we should continue the CDK4/6 inhibitors. We don't know if they should be continued after disease progression, whether PI3 kinase inhibitors will be good for patients with mutations, and other patients could receive everolimus. So it all remains to be seen with the goal of delaying the start of chemotherapy for as long as possible. So we've made tremendous progress in new agents to improve the response to hormone therapy. We now have 3 approved CDK4/6 inhibitors. I forgot to update this slide. And we're going to be doing studies for early stage high-risk breast cancer. So why is high-risk breast cancer being done? High-risk breast cancer is important because what you want to do is get these drugs to the patients who are going to benefit them the most. If you did a trial where you took everybody with hormone receptor positive early stage breast cancer and you randomized to CDK4/6 inhibitors or not, it will be 2 generations from now before we know the results. At least it won't be in my generation. So the issue is because patients do very well, and if you're seeing relapses at 15 years, it's going to take you a long time. Plus, we know that we cure a lot of women, most women with early stage breast cancer. So these trials have all focused on patients who have a higher risk of recurrence, either based on larger tumor size, higher grade, or positive lymph nodes. There will be 15,000 or more patients enrolled in these phase 3 trials, and one of the trials already has completed enrolling patients, and I'll show you examples of those in just a moment. So it's really exciting. We need the biomarkers, so there's a lot of smart people working on that, and I'm hopeful that maybe additional studies in blood will help us too. Should you get single-agent hormone therapy? Maybe only in the situation when patients who haven't received any treatment before for hormone receptor positive disease, where they don't want to take a targeted therapy or are concerned about it. There are a lot of aid organizations now which help with share of cost, and now because there are 3 drugs out there, there's so much competition. You can get a drug, the share of cost paid for if it's a lot, which it sometimes is for our patients with Medicare. The future of treatment for hormone receptor positive breast cancer is, I think, really exciting with a lot of different agents that are being studied, and we can talk about this more in a moment. I'm missing my slide that shows you all of the different trials that are going on. I'm not sure why it's hidden, but it's not here. But I'll tell you about those trials. At San Antonio this year, we'll see data on a trial looking at Ribociclib and endocrine therapy for premenopausal patients who are their ovaries are suppressed with an injection. Really important because our companies have actually been focused on excluding premenopausal patients on injections to suppress their ovaries, which seems terribly unfair. So it'll be great to have that data, although we now give these agents to premenopausal women on ovarian suppression all the time, and we have plenty of data showing they work. So this is just going to be additional data from a trial called MONALEESA 7. The adjuvant trials include all 3 drugs. after surgery, after finishing all the directed therapy, when you're on hormone therapy, you take the CDK4/6 inhibitor for 2 years or a placebo, and these trials either are blinded or there is no placebo arm, but you know right up front what you've been randomized to. And then lastly, there is a study looking at patients who didn't have a great response to chemotherapy given before surgery, neoadjuvant therapy. That trial is called Penelope, also an international trial. That one randomized patients to 1 year versus placebo of a CDK4/6 inhibitor, and that trial has just completed accrual to the trial. So with that, I'll finish and look forward to answering some questions.
Thank you, Dr. Rugo. I believe you answered many of the questions that were submitted beforehand, but we have a couple that people have typed in now. If you have any questions, now is your time to get them answered. But I wanted to make sure that the biggest question that many people are wondering about, you can reiterate, would it be beneficial for a patient to try another CDK4 inhibitor if one has failed?
Well, so it's a really good question. I think that you really have to look carefully at what's available for you, because right now we don't have any data that one CDK4/6 inhibitor is better than another, unless you had some sort of toxicity that made you not tolerate one. Let's say you got Abemaciclib and you couldn't tolerate it because of diarrhea or something, you could try an alternate one, not because your cancer grew. If your cancer grows on one CDK4/6 inhibitor, we have absolutely no data to suggest that another one will work. Abemaciclib is approved as a single agent without hormone therapy, but that was in patients who'd never had a prior CDK4/6 inhibitor. Where we're using them mainly now is when we add another drug, in clinical trials. So I think that that's still really a clinical trial question, and I would, save the side effects given the fact that we have no idea that it's going to work once you develop resistance.
Thank you. And someone is wondering, they heard that androgen receptors may have something to do with the effectiveness of CDK inhibitors.
Well, there's a lot of interest, of course, in androgen receptor targeting in triple-negative breast cancer, but it's kind of at a hiatus right now because such a small number of patients actually have the receptors and respond to the treatment with triple-negative disease. There will be a study presented at San Antonio using an androgen receptor antagonist for treating resistant hormone receptor-positive breast cancer, a drug called enzalutamide. But, it's hard to believe that those are going to have a role with all these targeted agents that we have, but it remains to be seen. So I think it'll be really interesting to see what it shows in the long run. So I think that what this trial shows, which you'll see in, I guess, another couple of weeks at San Antonio. In terms of the androgen receptor itself being any kind of a mechanism for looking at response to CDK4/6 inhibitors, that's not the case.
You mentioned that the drug may be, this class of drugs might be effective in HER2-positive disease.
Right, and that's why my slide that's not showing up for whatever reason is that's part of the issue. I may be able to pull it up now on the shared screen if I can escape, which I don't seem to be able to. There is a lot of interest to exit show. There's a lot of interest in HER2-positive disease because of that data I showed you with the cell lines and a number of studies which are ongoing. Let's see if I can find the studies, but I don't know what happened to my slide there of all the trials. I was having some trouble with my PowerPoint file, so that's potentially why. But I can show you this, actually, in just a second. Of all the different trials that are going on, I think it's really exciting to think about, what we're going to see in the future. So one of the trials, which I'll show you here in just a second, here we go. Should come up on your screen in just a second.
Yeah.
This shows you a variety of different trials that are going on, and actually what's really interesting here is that we're seeing, and I think you can see my pointer here, but we're seeing Penelope B is the one that's after people got neoadjuvant therapy, and then we have the PALOS trial, which is one of the adjuvant studies. Sorry about that. But what I have at the bottom, and I showed you the brain metastases slide too. Let's see. I think this is right here. Now you can see my cursor, right? Can you see it? Yeah. So brain metastases trials going on, adjuvant trials all here. But here's the bottom, which is answering that question, which is that there are a tremendous number of combination studies. One phase 3 trial, which I think is really interesting, is patients who have HER2-positive metastatic disease who get a taxane with Herceptin and Perjeta are randomized after they finish the chemo. They all get Herceptin and Perjeta and hormone therapy, and then they're randomized to Palbociclib or placebo for the maintenance, to hope that with Palbociclib we can keep people responding to treatment for much longer. So that's kind of an exciting trial. It's called the Patina trial. And then there are a number of other studies, as you can see here.
Thank you. So someone's asking, since the trials were for women only, can men with ER-positive metastatic disease, are they treated with these CDK4/6 inhibitors as well?
No, it's a really good question, because I tried to get Palbociclib for one of my male patients with breast cancer, and the insurance came back to me and said, you don't have any data on male patients. I was like, really? Anyway, so I sent them all of the information and explained to them that such a rare disease, you're not going to have a randomized trial, and they did approve it with a $1,000 share of cost, but we got that covered. But I think that, absolutely these data play a role for men with breast cancer, and most of the trials are now trying to include women or men to try and be a little bit more sensitive and generous in that. So, for example, the adjuvant trials.
Great. And someone is talking about that there may be a drug interaction with antioxidants and CDK4/6 inhibitors.
Yeah,
do you know anything about that?
There's not any data on that out there. These drugs, of course, have some effect on various pathways of metabolism, but not a whole lot. So one of the things about Ribociclib is that people have seen some EKG changes, and so you have to monitor the EKG for the first 2 cycles and not take drugs that cause those EKG changes that might be enhanced, but it's pretty uncommon. In terms of, the other drugs, there isn't, we know that there are some very low-level interactions, but certainly not antioxidants. I'm not sure what the person heard, because there isn't any data to support that.
Okay, and I just want to remind the audience to submit your questions. I have one more question. You have 6 minutes with an expert in the field here. So get your questions in now. So my last question is that you mentioned that older patients have lower blood counts. And so someone wants to know if you can define older.
Well, so, it's always hard, actually. I have a study coming out of, the quality of life in older patients, and they put elderly, and it was like 65 or older. I said to them, look, I can't say elderly for 65 or older. So they did agree to change it to older, but it was quite a struggle. So, elderly generally is 75 and older, and there's usually smaller numbers of patients, obviously, enrolled in trials who are 75 and older. But when we looked at the 75 and older patients, they had a little more neutropenia or low neutrophils, but they didn't have any more side effects that were serious, so no fevers or hospitalizations or serious toxicity. So I think that, although you get a little bit more bone marrow suppression, people seem to tolerate it. Anecdotally, in my clinic, I found that women who are older, and I'm talking about 70s and older, they get a more fatigue with these drugs. And so I tend to dose reduce my older patients much more frequently than younger patients.
Mm-hmm. So now a bunch of questions are coming in. Are drug vacations effective before starting another treatment for MBC?
Well, so I don't know what drug vacations effective are. So you don't, so in general, I mean, the only data on drug withdrawal is having some reduction in diseases with tamoxifen, and that's really small, and we just don't see it much at all. Where you're withdrawing something that may be having a sort of alternative action on the cancer. But the reason why we do drug holidays, 2 weeks or something like that for clinical trials and for treatment in general, is to allow the patient and the bone marrow of the patient, et cetera, to recover from any side effects so that you don't enhance the side effects. That's really the reason for these sort of intervals. Other than that, a treatment holiday for metastatic disease doesn't have specific effectiveness except for quality of life and allow people to travel and, et cetera, et cetera. Those are all good things. There is some data that patients with triple-negative disease who stop treatment and wait for it to grow again actually live a shorter time. So we generally continue treatment, which has been a big push to try and identify what to use in maintenance for people with triple-negative breast cancer. You need to be on chemo forever. It's kind of disappointing. For hormone receptor-positive disease, it's a little easier because we can use hormone therapy for maintenance, so to speak. But, being off therapy, again, is a way to recover from side effects generally.
Thank you. So someone is asking, is it up to the oncologist as to which therapy to use and in what order for metastatic breast cancer? Can you talk about that a little bit and maybe about the NCCN guidelines or ASCO guidelines for treatment as well?
We have ASCO guidelines that are updated regularly, the NCCN guidelines that are online, available to everyone, that are updated every year, and then we have an Advanced Breast Cancer International Consensus group that publishes results every 2 years about sort of general consensus about treatment called ABC, and we just had ABC4 in Lisbon, and those I think help a lot. But in general, every treatment decision for a patient should be a conversation between the patient and his or her physician. It can't be a unilateral decision. But in general, yes, there are guidelines and recommendations, but in the end, it is the oncologist's decision with the patient. And I've certainly seen patients where the treatment is not something which I consider standard or even reasonable for patients. On the other hand, there are certainly options where there are a number of different treatment considerations that could be taken into account. And then, you make the decision talking with the patient, okay, we need to use chemotherapy. Let's start with an oral treatment because that's going to be easier for you, and you don't lose your hair with that, and you can travel, and it's, there's no data that getting the other one that makes your hair fall out or a combination therapy is going to help you live longer. For example, that kind of a conversation I always talk to patients about what options exist and what I'm thinking about doing. And, each patient is quite unique in terms of how much they want to participate in that conversation. In general, I think people do seek out the oncologists who've talked to them a lot who want to participate. So I would say my group of patients participate fairly a lot in these discussions.
All right, we have time for one more question. I'm not sure what this means, so I'm going to ask you, and hopefully you will know. Should MBC patients now get a cell-free DNA when resistance to a treatment develops?
Well, it's still considered experimental. We don't really know. I think that it can be used for screening if there's a trial for a PI3 kinase inhibitor for which there is a, you could be eligible if you had it, because although the trials may require tumor tissue, if you've had an initial screen from blood, of course, it's really easy. Then you know if you need to have a tumor biopsy. The other thing that you could look for that could be targeted in a trial, and there are a lot of trials, 2 trials going on nationally on this, is a tiny percent of patients, mostly those with lobular hormone receptor-positive cancer, can have mutations in HER2. So they don't have HER2 positivity by the standard mechanism, but they can have mutations. And those patients may have a response to the oral agent, neratinib. So, but again, unless you are going to go on one of those trials, it's not worth really looking for it because, you're not finding approved drugs that way. And the number of patients with mutations are very small.
Thank you, Dr. Rugo. I think that's all we have time for today. Thank you for your time in the program. Thank you all for participating. If you submitted a question and we were unable to answer it, feel free to call the SHARE helpline. A trained volunteer can help you out. You can reach the helpline at 844-ASK-SHARE. I think that's right. 844-ASK-SHARE. And if you wouldn't mind just taking a moment to fill out the survey at the end of the webinar, it helps us to create future programs that are appropriate. Dr. Rugo, thank you so much. We really appreciate your time.
Thank you.
Bye, everyone.